Welcome everyone to this seminar by Dr. Bradley Stoner, Getting Burned, Global Health Disparities in STI HIV Care Prevention. I'm Professor Allison Dundee-Drentel in the Department of Political Science and International Relations. We are delighted that you are here for another human rights program in Dornside College. It gives me great pleasure to begin. We have two luminaries in the discipline of public health and human rights. What an extraordinarily important discipline, and these two have made enormous contributions at every level of government, including global health. We are so honored to have a chance to hear from them today, and also tomorrow at a panel at 4 p.m. in the Tudor Center. The importance of the topic is clear from the number of co-sponsors, but please allow me to thank them before I introduce our distinguished moderator, Professor Sophia Gruskin. We would like to thank the Center for International Studies, previous director Greg Treverton and Sayori Katada, the current director, associate director Dr. Matt Stevens and Linda Kim for taking the lead on organizing today's program. In addition, we wish to thank the Center for the Political Future, especially beloved Bob Shrum, the USC Institute on Inequalities and Global Health, the USC Equity Research Institute, especially Manuel Pastor, Dornside College Departments, Anthropology, Gender and Sexuality Studies, POIR, and Sociology. Special thanks to Sally Pratt, our chair, Kathy Ballard, and Edgar Ramirez, who made our posters, which are great. We also wish to thank the Narrative Medicine Program at Keck School of Medicine, the Levin Institute for the Humanities at the Price School for Public Policy, and the Blackstonians Pre-Law Honor Society. Now I have the privilege of introducing our very own wonderful Professor Sophia Gruskin. She is one of the leaders in the field of health and human rights. Some say she's the one who created the field. Her bio is so impressive. It will take too long for me to list all of her accomplishments, but she is the director of the USC Institute on Inequalities and Global Health. She is professor of preventive medicine and chief of the Disease Prevention Policy and Global Health Division at the Keck School of Medicine, professor of law and preventive medicine at the Gould School of Law, and an affiliate faculty member with the Spatial Sciences at USC Dornside. She's on the board of the USC Academic Senate and has run a wonderful collaboration on law and global health. She's on many international boards and committees and has published a great deal. She's one of my heroes, and I feel so honored that you're my colleague. We're so lucky to have such a superstar here at USC. So I think I'm going to make sure everybody reads her bio online, but I don't want to take up any more time. She will now introduce Dr. Stoner. Thank you very much for coming.
Allison, you are way too kind. Okay, that was amazing. Okay, so thank you to you, but thank you to everyone for being here, and welcome to Getting Burned, Global Health Disparities in STI, HIV Care and Prevention, a conversation with Dr. Bradley Stoner. So as Allison said, I'm Sophia Gruskin. I direct the Institute on Inequalities and Global Health here, and I'm really honored to have been invited to introduce Dr. Stoner, the person. And I want to start by saying something about the event and several reasons why I think this event is so powerful and relevant and exciting. And the first thing is points to exactly what Allison was just talking about, which is the collaboration. It is so rare to have all of these different parts of USC coming together to support one another. And I think that that's something so special. And it's really, I want to say, of course, how important the topic is, but it's also really a testament to you, actually, and your passion about the work and how it is that you bring us together. So I actually want to thank you. Okay. Yeah, absolutely. Second is in terms of our wonderful speaker, who comes to us all the way from Queen's University in Kingston, Ontario, Canada, and his work with HIV and STIs is known the world over. I'm very much looking forward to what he has to say, because having read his work, we've never actually met today. So it's very exciting to think about the potential intersections between his work and the current priority issues at the Institute. So I'm going to give a couple of snapshots to show what I mean, but it's also kind of a shameless plug for the Institute. All right, so you all get a sense of kind of the work that we do here. So one thing is that we host highly high-level events a few times each semester online to address health inequalities. This past week, we hosted an event that Dr. Stoner attended virtually, which was on HIV/AIDS and the longevity dividend, strengthening health systems and advancing equity in aging societies. And we had an amazing group of speakers from around the world. But it really is, for us, the issue that when we think about people living with HIV, health systems should be much better adapted at how it is to support folks to actually have integrated person-centered care for people living with HIV. It's not something our health systems in the United States or around the globe is really ready to do yet, but it should. And it really is, I think, really kind of a testament when I think about your work and I think about kind of your work around STD prevention, treatment, capacity building. I think that there's really a linkage there in terms of some of the things that we're thinking about. Second, we work closely with a lot of UN agencies, government, civil society, and academic partners in pretty much all corners of the globe in terms of the research that we do, but also in terms of policy engagement and in terms of education. And we do this in a range of topical areas, but with the kind of scary things, for a very technical term, scary things that are happening around the globe right now in terms of regression, in terms of commitment to sexual health and rights. It's very much a deep concern. It's something we might want to come back to in the discussion. But what that's done for the Institute is it's bumped sexual health really to the top of our concerns, which is another reason I think that this talk is so timely and important. And perhaps most relevant here is we're very focused on student programming. And we're doing things that are really trying to increase educational opportunities for students to be able to have the tools necessary to be able to talk about and address sexual health issues. The reality is, even here at USC, that sexual health and rights are generally not very well covered. And in a lot of what's offered to students. And so what we're really trying to do is to kind of shine a light on that and think about more positively what is it that we can do. We've been trying to take this on a bunch of different ways. One of our annual fellowship recipients just returned from South Africa, where he was working with local partners on genome sequencing for a potential syphilis vaccine design. So there we go, something that seems, and we're very proud of what he's done. But I say this to make clear that his work is just one effort by students to try to work to combat global health challenges. And there's obviously important synergies. This last summer, just one more thing I wanted to say, is this last summer we worked with 14 USC undergraduate and graduate students to create digital content on sexual health and wellness, which was really an effort for students to be able to speak to other students at USC and beyond through TikTok and through other social media channels about sexual health and rights issues that they found most pressing. And interestingly, I think many students chose to make content that was at the intersection of comprehensive sexuality education and STI HIV prevention. And so this content is really super exciting for how it is to be able to think about what we could do with this going forward. I've learned a ton through this project in terms of trying to understand communication through TikTok. And I have to say, it's more effective and perhaps actually more fun than what we do with peer reviewed journals and policy briefs, right? So this whole kind of new way of thinking about things I think is very important. So I just moving now to the topic at hand. You've all seen on the flyer that this presentation is going to explore how and why the right to health is fundamental to the human condition. And I think give important insights as to why across the globe, nonetheless, achieving sexual health remains an elusive goal. Rates of sexually transmitted infections continue to climb everywhere. Accurate information is harder and harder to access, and access to effective HIV prevention methods is uneven at best. So through his anthropologically informed analysis, I think Dr. Stoner is going to be able to offer us a lens on the ways in which social and structural factors sustain and strengthen disparities in sexual health, rather than in the current moment leading us towards a better sexual health. So I hope you're all looking forward to this conversation as much as I am. And let me formally introduce Dr. Stoner. He is professor and head of the Department of Public Health Sciences and professor of medicine at Queen's University in Kingston, Ontario, Canada. His research focuses on the clinical epidemiology of sexually transmitted diseases and sociocultural factors that influence infectious disease risk in human populations. And he's got a huge list of amazing credentials, so it's kind of hard to know where to start, where to stop, but I'll just say a couple, and Dr. Stoner, apologies if I'm not pulling out those things you consider to be the most important. So he is the former Chief of STD Services for the St. Louis County Department of Health, Medical Director of the CDC-funded St. Louis STD HIV Prevention Training Center. He also served as chair of the CDC-HRSA Advisory Committee on HIV, viral hepatitis, and STD Prevention and Treatment. He is past president of the American Sexually Transmitted Diseases Association and currently serves as North American Regional Director for the International Union Against Sexually Transmitted Infections, and so much more. So I hope, I really look forward to the presentation. It's an honor and a pleasure to have you with us today, and the floor is yours. Thank you.
Thank you very much, and I'm very honored to be here. I'm a little embarrassed to hear those things, but thank you for those kind remarks, and thank you to Professor Wintel for organizing this, and to Professor Greskin for serving as the moderator. It is a delight to be at USC, and I hope I live up to the expectation. I like the way that Professor Greskin introduced this as a conversation, because I would like it to be the start of a conversation. I think this is such a broad topic, and I'm just going to be hitting certain highlights, things that are important to me, to give you a sense of what I do and why this is important. I usually start with disclosures, and I want to disclose no commercial or private funding, but I do want to express grateful acknowledgement to collaborators and funders from the public sector in the United States and Canada. And here are just a number of the agencies that I've worked with, collaborated with, and currently receive support from financially as well as intellectually. These are agencies that have the public interest at heart, and that's really where my remarks are focused. I do want to say that as you see St. Louis County, so I am from the U.S. I lived in St. Louis, Missouri for many years, and was in fact a member of Washington University before decamping to Canada. So a lot of my research really crosses the border between the U.S. and Canada. But being Canadian now, I want to start with a land acknowledgement. And I know it's not as common here, but I found out that USC also, as all places in North America, inhabit or are located in areas that previously were inhabited by indigenous communities. So with humility and respect, I recognize that the USC campus is located on the traditional, ancestral, and unceded territory of the Gabrielino Tongva peoples. And to acknowledge this territory is to recognize its longer history, one predating the establishment of the earliest European colonies. As uninvited guests, we are grateful to be able to live, learn, and play on these lands. This is something we do for every meeting, for every conference in Canada. And I think increasingly in the US we're seeing this. But it doesn't go far enough, does it? It simply acknowledges that here we are, and it was yours, now it's ours. And so there's no reconciliation effort. But Canada's a little bit farther along in terms of dealing with this, and this past Saturday was the National Day for Truth and Reconciliation in Canada. And this is a way that we honor what the Truth and Reconciliation Commission in Canada established, the 94 calls to action to recognize past grievances and abuses towards traditional peoples and our efforts to work towards a more just and equitable society. So in that spirit, I wanted to offer my remarks today. And also to thank all the sponsors. I'm going to read the list of sponsors, but it will take too long. And I thank Professor Wintel for organizing this incredible list of groups to sponsor this session today, and thank all of you for coming out here. What I want to talk about in the next 30 or 40 minutes really is to give you a little bit of a tour of the kind of work that I do. I'll start with some disciplinary foundations that you gathered that I've come from the discipline of anthropology, but I also work in medicine, so I'll say a little bit about that. I'll talk about STIs because my clinical work really is in the area of sexually transmitted infections. And we'll start first on North America because that's where most of the data comes from. And of course, if we're living in North America, what do we know about what's going on with STIs and why is that happening? We'll look at how COVID-19 impacted STI epidemiology. did that help or hurt us in our prevention efforts? And then we'll move into global disparities in sexual health and compare North America to the rest of the world. What do we know about what's going on elsewhere, and what's our responsibility? And finally, we'll follow up with, and Professor Rentel rightly situated this as part of the Health and Human Rights program. Is sexual health a human right, and how can we work towards that in the future? And then we'll open it up for conversation and questions. So that's where I'd like to take us the next short while. So foundations, in anthropology, we talk about positionality. And Professor Rentel and I have had to talk about this, and this drives her to distraction, because what does it mean? Well, it means who you are and why you're in this space. And so I want to disclose that I am as a white male a clinician with an anthropological background. I'm working in a space that affects marginalized communities, and I see myself as an ally and working towards the advancement of social justice in this area where there's profound disparity of healthcare outcomes and healthcare access. But to put myself in that space is really important, because anthropology is a reflexive discipline, and it's one where we engage with the other, and the other then affects us. There's no independent objectivity. It's a collective engagement, and so I want to disclose that, as I tell you what I'm seeing in the world, that you can interact with that, and you can see that it's affected me, and it's driven me to do things in response to that. So my positionality in this. My disciplinary perspectives, I am trained in internal medicine, and specifically in infectious diseases, but I also have a PhD in anthropology, and so we could talk about that, how that happened, but there is more and more interest in doing these kind of social science and medicine MD PhD programs, and I think there's tremendous value in that. And I have moved into a field which I call public health anthropology. So it's not medical anthropology per se. Medical anthropology is understanding how people deal with health systems. Public health anthropology is really about how systems deal with each other and within the larger macro environment. The theoretical orientations, I draw a lot from critical medical anthropology, which was foundations put forward by Meryl Singer and Hans Bayer, well, 2 or 3 decades ago, that explicitly addressed the social origins of health and disease, and as well as the social, political, and economic contributors to health inequalities. Inequality is not necessarily inequity, but the first step is recognizing where are things not equal, and then we can make decisions about what's inequitable. And also places the sufferer experience within frameworks of hegemony and resistance. I think this is really, really important, because sufferers, the healthcare seeker, the person receiving the care or lack of care, can affect change through a collective action. I think that's really important to note. I also want to acknowledge eco-social theory, an early collaborator of Professor Gruskin's, Nancy Krieger, who really put forward this idea of webs of causation. We've known about this for a long time, but we do not have unilineal patterns of causation. We know we have germs and we have infections, but those don't occur in a social vacuum. And so we have to look at not just the individual, but also the microsocial, macrosocial, and societal contexts of those infections. So those are kind of the theoretical orientations of the work that I do. Now let's turn to STIs. This sort of headline happens all the time. It's not news anymore. This happens to be from 2019, but from New York Times. Sexually transmitted disease cases rise to a record high. I'm starting before COVID because I want to look at COVID as a moment that kind of affected things. But this was something that was happening all the time, and STI rates have been going up really since about the year 2009, 2010. They've been sort of flat before that, but for at least a decade, 2010s rates were going up, and for the ones that we track, gonorrhea, syphilis, chlamydia. So you would see headlines like this all the time. Usually in about September or October, when the CDC surveillance statistics would be released from the previous year. It takes about 9 or 10 months for the previous year's data to get amalgamated, and then the CDC publishes a document called the surveillance STI surveillance report, and every year rates go up, and so you'll see reports like this. I actually got, when I was at WashU, called in to talk about this, because St. Louis historically was always at the top of the list. So you can see me doing my part, just trying to explain what the rates are, just trying to make a dent. And so I think some of that social advocacy is really important work, so that we can raise awareness, but it's not going to solve the whole problem. So I want to start with a vignette and some of the work that I had been doing at the time, some of the clinical ethnography that I had been engaged in St. Louis. So you're in St. Louis, Missouri. It's Friday morning at the clinic, the North Central Community Health Center on Jennings Stations Road in the heart of urban Pine Lawn, Missouri, which is one of the peri-urban communities in St. Louis. People are lined up down the hallway, already waiting to be seen in clinic this morning, and it's only 8:15. As fate would have it, I recognize one of the men standing in line, a charismatic young fellow in his mid-20s, gregarious, energetic, likable. Andre, I think his name is. Hey man, he says to me, bet you didn't think you'd see me back here right away. And he's right, actually. It had only been about 3 or 4 weeks since he was last here. And I smile and I engage with him, careful not to use any personal identifiers that might reveal his identity to anyone else waiting in line listening to our conversation. What's up, my friend? Always a pleasure. Back so soon, I see. How are things? Andre pulls me aside and addresses me directly. Yeah, well, things happen, you know, and people are people. You know what I'm saying? Well, I'm not entirely sure I do know what he's saying, but this is a sexual health clinic, so I'm gonna go with it for a minute. As you know, he continues softly, well, I got burned. I got burned again. You know what I'm saying? And so getting burned, now I do know what he's saying. I've heard this a lot before, getting burned, getting burned, not burnt, but burned. It's a colloquial, well-understood expression among young men attending sexual health clinics describing the burning sensation that they experience when they get gonorrhea. Getting burned means acquiring a sexually transmitted infection, usually gonorrhea, because when you get it, it burns down there. More broadly, it refers to something bad from someone who you really didn't think would do that to you. Euphemisms abound in the sexual health clinic, and people like to speak obliquely about their current circumstances. Typically, getting burned is an expression of surprise and disappointment. You get close to someone, you feel like you're making a connection, you become intimate, and then a couple of days later, when you develop uncomfortable sensations, such as burning when you urinate, and you notice a yellow or green discharge, this tends to give you pause for concern. In many cases, if not most, people feel that their partner intentionally misled them and knew they must have had something but didn't tell them before they had sex. So men who get burned are by turns surprised, upset, angry, and disillusioned. Why didn't my partner tell me? They must have known and decided not to get checked, or decided not to tell me for a variety of reasons. And a similar dynamic unfolds with regard to transactional sex. Men who provide money, drugs, or gifts explicitly in exchange for sex, and then develop symptoms, and also describe this as getting burned. But in these cases, it's less a slap in the face than a reminder of the fact that condomless sex is a risky enterprise. Getting burned then is a reflection of acceptance of the unfortunate circumstances in which you find yourself. Now, my goal today is not to make you all expert STI clinicians, but rather to share with you a number of observations of what it's like to live with STIs in the 21st century. This is not something most of us think about on a day-to-day basis, but for a certain segment of the population, it's a very real occurrence. Too often, it's the individuals least able to buffer themselves from these threats who are most likely to become affected. Lacking access to preventive resources at the individual level, they are also unable to mobilize much public support in their plight, primarily because we come to see these conditions as failures of personal responsibility, a result of character flaws or intentional behavioral choices made by people who ought to know better. Anthropology provides a useful platform for investigation, as well as an analytic framework to discern why STIs perpetuate in society year after year, and why the US and other developed countries continue to fail to implement the necessary social and political tools to keep a lid on these infections to a very great degree. And as bad as it is in the US and Canada, it's even worse, profoundly worse across the global south. So this is a story of the anthropology of everyday life in a world of STI treatment, prevention, and control. So getting burned in my model is a metaphor. It's what happens at the individual level. It's also a metaphor for what's happening at the global level in terms of the failure of systems to enact the proper care and prevention strategies. So let's turn to STI rates. I'll give you a quick snapshot of what we know. These are data that come from the CDC, and they're surveillance data. Every year we get these kinds of slides, and you can see this are reported cases of syphilis, and I've got several of these, and I'm just going to give you the big picture. But what you see here are, since about 2010, rates of syphilis have been going up, mostly in men, but increasingly in women And so the total rate is sort of in the middle. These are rates of detection. So there could be some bias in terms of women not getting detected because they're not getting screened as often, which is the opposite of chlamydia, where women actually get screened more than men. So there's a detection bias there. But you see that rates are going up for syphilis year after year. Same thing for gonorrhea. And the same thing for chlamydia. And here's the one I mentioned, rates for women are higher than rates for men. And this is a consequence of the fact that women are often diagnosed with chlamydia in family planning settings when they're going in for reproductive health care and they're getting a routine STI check because they're getting birth control or other forms of reproductive health care. So they access care and they're getting screened. They're not having symptoms, but they're actually getting screened and they're getting detected more. And as bad as it is in the US, Canada has had even starker increases. And so you'll see these are Canadian syphilis rates that really shot up since 2017. So there was a lot of hand-wringing. And again, I'm going up to 2019 because COVID hits in 2020, and I want to use that as a moment to compare. So these are the syphilis rates in Canada, but you see the male-female disparity. Here it says male-female. It's really men and women. We're talking about self-identified. So we could talk about that too. Is it male? Is it men? These would include, for example, transgender men would be in the male category, unfortunately. So Canada is a little farther behind than the US in terms of reporting. And gonorrhea rates going up. You see kind of flat lines from 2018 to 2019, but still over that previous decade, increasing rates. And maybe a less steep incline for chlamydia, but still rates rising year after year. So this is a concern across the developed West. It begs the question, so what are we talking about? Well, we're talking about sexually transmitted infections, and these are infections transmitted from person to person through sexual contact. They represent a significant cause of morbidity, both in terms of the immediate pain and suffering that people experience, but also the long-term sequelae, or the consequences of infection. So undetected, untreated chlamydia is thought to be the #1 cause of tubal factor infertility in women of reproductive age. Many women who are undergoing fertility-assisted reproductive technologies, fertility procedures in their 30s and 40s may have had undetected and untreated chlamydia in their teens and 20s. And so STI detection and treatment is a fertility prevention strategy. So we see it as a way of preserving people's abilities to make reproductive decisions in the future, as well as pain and suffering that comes from long-term infections, ectopic pregnancy, tubal scarring, tubovarian abscess, lots of things that can come from undetected, untreated STIs. And we spend a lot of money dealing with these in terms of outreach and prevention, as well as partner notification. I'm often asked, is it STD or STI? And you'll hear we're sort of in a moment where it's sort of flipping back and forth. Is it STD or STI? So I came of age when we were calling things STDs, sexually transmitted diseases, and it's become a long-standing, generally accepted term, particularly in the United States. And it replaced an earlier term called venereal disease, or VD. And if you're old enough, you'll remember the term VD, and it was a euphemism for something that was venereally transmitted. And that always struck me as peculiar. Why would something be venereally transmitted? What does that mean? Well, it comes from Venus, the Roman goddess of love. So it itself was a euphemism. VD was really a euphemism for any sexually transmitted infection. And in the pre-penicillin era, VD meant either syphilis or gonorrhea or both. And it's something that you got from women in the evening, or sailors would get it when they were on shore leave. And so there were lots of VD prevention strategies that didn't really work, focusing on specific populations. But in about the 1990s, the term STI came of age. And so you'll start to see use of this term, sexually transmitted infection. It's become the term of choice in Canada, in Europe, in Australia, and the US are laggards, I think, in terms of using this term. And I think it implies that asymptomatic infections may not cause actual clinical disease, and it may be less stigmatized. If you think it's just an infection, we all get infections, but we may not be diseased in the classic sense. So I think STI is probably the better term, and I try to use that now in my language. But I will point out that the CDC still has the Division of STD Prevention. They still come out with the sexually transmitted disease rates. And the reason is, and I'll get to this in a second, is that only 3 diseases are actually tracked by the CDC: syphilis, gonorrhea, and chlamydia. Out of all the others, there are close to 20 STIs, but only 3 are reportable infections. So you can think about herpes, you can think about human papillomavirus, you can think about all the other types of infections that people get in the genital area, pubic lice, and none of these are reportable conditions in the classic sense, and the CDC doesn't have the resources to deal with them, and so they've contracted around these big three, the sentinel three, and they use them as markers of the larger problem. So STI is the better term, but STD is still out there. How many STIs are there? Well, these data come from the CDC. These are estimates of incidence and prevalence of STIs. It comes from 2013, but it's probably not a bad estimate. About 20 million new infections occurring per year in the US, most of which are human papillomavirus infections. So 14 million HPV infections occurring per year, many of which actually get cleared immunologically without treatment. So HPV, there are many different types of HPV. You can acquire it, it can actually go away. Focus though on the ones that you would need antibiotics to treat. Chlamydia, trichomonas, gonorrhea, syphilis, probably about 4 or 5 million cases a year if you count those infections. And these are not case counts, these are actually estimates based on population-based data. So 20 million new infections and about 110 million people in the US have an STI at any point in time. And I used to, when I was teaching at WashU, I would say, how many people live in the United States? About 330 million, 340 million. So a third of Americans have an STI at any point in time, and most of which are HPV infections. But that's a staggering number. So there's a tremendous amount of morbidity. Now, as I mentioned, many different pathogens can be sexually transmitted, and here's just a laundry list of the different kinds of germs that you can get through sexual contact. But not all STIs are reported and tracked, and if you look closely, it's really just chlamydia, gonorrhea, and syphilis. And then HIV, of course, which is a special STI, it's also a bloodborne infection. And in Canada now we're using the term STBBI, sexually transmitted and bloodborne infections, and that encompasses hepatitis C as well as hepatitis B. So putting those together makes a lot of sense. And a few others that are unusual, chancroid LGV are reportable, but really gonorrhea, syphilis, and chlamydia are the big three. So I want to ask the question about COVID-19 and STIs. How did the COVID pandemic affect STI rates? And I set a little timer so that I don't get ahead of myself. I don't want to speak for too long. Well, social distancing recommendations came out. Everyone remembers where you were in March of 2020. I remember where I was because I was telling my students, have a good spring break, we'll see you afterwards. And there was it was all Zoom after that. I even brought a mask as a joke to the spring break meeting, saying, "Oh, CDC says these aren't necessary, but if you need one, I've got a few masks." And everybody thought that was funny. And then everything became reality, and we were all living in a world of social distancing. Well, there were shelter-in-place recommendations, reduced social contact recommendations. Those of us on the STI side thought, well, this is good for our field, right? We can't get reduced rates of syphilis and gonorrhea any other way. Why don't we keep people apart from each other and see what happens? So this should reduce the number of sex partners, theoretically, right? And it should lower the rates of STIs. So we thought at least, that was the silver lining of all of this, that COVID-19 ought to lead to reductions in STI morbidity. What did we see? Well, we actually started to see profound initial decreases in chlamydia, gonorrhea, and syphilis, and that is consistent with the theory, isn't it? Right? People are staying away from each other. They're not having as much sex, so we're seeing less of these infections. Data out of Rhode Island, some colleagues of mine who are in Providence put together their clinic attendance data. Visits, and then the other lines, there's screening visits, the dashed line, and the bottom line, this is worrisome, treatment visits. These are people with known infections who are coming back to get treated. They didn't get treated on the day of exam, they get called back, and but number of visits are going down, so the treatment visits are going down, so they're probably detecting less infections. So this could be a good thing, right? So visits, same thing happened if you look at the number of tests being performed at the US National Reference Clinical Laboratory. The gonorrhea CT is chlamydia trachomatis, and GC is gonorrhea. It's an acronym for the gonococcus. So the chlamydia and gonorrhea nadir occurred in April 2020. Significant decreases in the number of tests performed and declines in testing, but strongly associated with increased test positivity, meaning the percentage of tests testing positive went up. so that it wasn't just the worried well coming in getting screening tests, it was actually people who had infections. So that could be a good thing too, right? You're restricting access to people who need it the most. And you can see this is a weekly counts of the number of tests, gonorrhea at the top, I'm sorry, chlamydia at the top, gonorrhea at the bottom, starting in 2019. And you can see week after week after week, pretty much the same number of tests being performed until you hit March of 2020. And those steep decreases represent the decline in the number of tests being performed for chlamydia and gonorrhea. But a strange thing happened. What do you think happened? Within about 3 or 6 months, people started noticing rebound increases in rates of gonorrhea, syphilis, and chlamydia. Now, maybe this is just the pent-up demand. Maybe these were people that just had undetected infection that didn't get treated before. Well, we wish that were true. What we're really seeing is significant increases going up beyond where we were in 2020. The resumption of this trend, remember the trend line going from 2010? So you see a blip in 2020 and then the resumption, and the rates continue to go up. And it's even worse because in women, the line is even steeper for syphilis. And if you look at this graph, the only thing you need to know about this graph is this is the number of tests performed in 2020 and 2021 relative to the number of tests performed that same week in 2019. So this is a week per week comparison. And if you're in the blue, I'm sorry, not number of tests, number of new cases of, and this happens to be syphilis. The number of new cases of syphilis in 2020 and 2021 relative to 2019. If you're in the blue, then you're above where you were in 2019. If you're in the red, you're below where you were in 2019. For about 5 or 6 or 8 weeks, we had less syphilis in the United States than in 2019. But then rates took off and it exceeded where we were in 2019. So every week thereafter, we weren't just caught up, we were again higher. So social distancing didn't work, unfortunately. And the same thing happened in Canada, where infectious syphilis rates increased 20% between 2020 and 2021, following a period of decreased access to, here you can see STDI, sexually transmitted and bloodborne infectious services during the COVID-19 pandemic. And so it's not that we came down and went back up to a plateau, it's that we paused and people were still having sex and still getting infected but had nowhere to go. And when clinics opened back up, then you saw an even higher rate. And so that there was a paradoxical magnification, if you will, of STI that got caught up. And congenital syphilis, this is infection in newborns, and it shouldn't occur because you can screen pregnant women for syphilis and treat them and prevent infection from occurring in the newborn. When a baby is born with syphilis, that's a serious condition. And Canada went from 7 cases of congenital syphilis in 2017 to 96 cases. So this was probably a consequence of the shutdown. Not that people were having less sex, but that people had nowhere to go when they got the infections. So this is a concern north of the border. Gonorrhea, the same sorts of things are going on. You start seeing increases in rates again. You don't even see the blip for 2019, I'm sorry, the 2020 blip. It basically disappeared. And when you look at this graph, there was just another very short window when we were below 2019 rates, and then we're back up again above 100% where we were in 2019. So for gonorrhea. And for chlamydia, now chlamydia, you might say, well, this is a good sign. So we actually went down with chlamydia testing, and in fact, we're in the red across the board. But what this really means is we're not back up in terms of screening asymptomatic carriers of chlamydia. So there are a lot of women out there that remain undetected who are having chlamydia that aren't getting detected and treated. So this is what COVID did is it magnified existing health disparities. Because if you're in the private sector in the United States, you usually have access to healthcare and you can get tested and treated if you want to. Many of these cases fall into the public sector and publicly funded STI clinics and sexual health clinics around the country, and access still has not been brought back to where it was previously. So after COVID-19, we actually saw pretty significant increases in chlamydia, gonorrhea, and syphilis, and in particularly congenital syphilis. And when you look at by rates of men and women, the rates profoundly increasing in women for primary and secondary syphilis, the infectious stages of the disease. So same things are going on in Europe. In the UK, sharp declines in testing, but partial rebound later. The data are not as good. The nice thing about the United States is that CDC does a very good job of collecting and releasing surveillance data. So we know what's going on here to a much greater degree than we do in some of our partners. But in Australia, they looked at actually attendance at the Melbourne Sexual Health Center, and 7 weeks pre-lockdown. During the lockdown, they saw cases within symptoms only, symptomatic people, and so the number of people seeing this asymptomatic screens went way down. But the 7 weeks post-lockdown, they rebounded. So you see this pent-up demand for sexual health services that isn't going away. So I don't think social distancing really helped reduce STI rates. And these are the graphic data for what's happened in Melbourne. Not quite back up to where they were in terms of the pre-lockdown. So sexual health services haven't come back. So you can imagine here in the developed West, and that's part of what I'm going to talk about. As bad as it is, imagine how much more amplified it is in developing countries that have less resource access. So after COVID-19, we saw unwelcome increases in STI rates that I think reflect reduced screening, leading to longer durations of asymptomatic infections and greater opportunities for transmission, and unmasking and magnification of underlying health disparities. So this is where I wanted to take our conversation today, was what's our responsibility in the sexual health field? Should we pay attention to these? It's, to the extent that we have individualized sexual health decision-making, place the responsibility on the individual. But if the individual doesn't have access to care, we're casting them into networks of despair, really, because their concern can only get worse. So global STI epidemiology, I've given you a snapshot of where we are. I know it's kind of depressing, but there's some exciting new interventions on the line. You might have heard of DoxyPEP and DoxyPrep coming down the line for syphilis prevention. So I'm not going to talk much about that. But high-income countries have comprehensive surveillance systems, interconnected data networks, real-time program responsiveness. We can respond to outbreaks. We have the resource basis to do that. Imagine low and middle-income countries. Very paucity of data, incomplete data collection, and incomplete data reporting. These are the global estimates of STIs in the world based on WHO estimates. And you can see 374 million new cases. These are incident cases of STIs, 340 million new infections. Notice the term curable STIs. WHO has taken the position that they're only going to focus on infections for which they can provide medication. Remember when I talked about what's going on in the United States, and I said 20 million new cases of STI per year, 14 million of those of which are HPV? That's not a curable STI. And you contract to the other 6 million of the 20 as gonorrhea, chlamydia, syphilis, and trichomoniasis, and that's what they're talking about here. So of the 374 million new infections globally, 6 million occurring in the United States, maybe another, I don't know, 800,000 in Canada. The rest of this, when you're seeing the North America, 74 million, it's really Latin America. It's the Southern Hemisphere. And so when we talk about the Global South, we're really talking about this disparity between a high income and middle and low income countries. So profound need, and the Americas have their share, but most of the morbidity really is in other parts of the world. Western Pacific, Southeast Asia, and specifically Sub-Saharan Africa. So that's really where the profound disparities exist. We're not even talking about viral STIs. And these data are from my colleague Theodore Oakley at the World Health Organization. Genital herpes simplex virus infections estimated to affect over 500 million people globally. And so that's a completely different issue. 1 in 7 women are estimated to have prevalent HPV infection. So these are concerns, but we've backburnered them because we're still dealing with the curable STIs that we can't cure. It's an issue, and so that's where I put a lot of my energies lately. Just to point out how are global estimates developed? Well, not very well, not very accurately. We don't have the same kinds of robust surveillance systems. We have sentinel surveillance in certain clinical venues, what are called ANC clinics. If you worked in global health, you've heard this acronym ANC. Here in the United States, we call them prenatal care clinics, but antenatal care, HIV clinics, other kind of clinical research settings where they're actually testing for infections as part of a clinical research program. And then they extrapolate to the general population. So for example, you'll get something like this. These are chlamydia estimates from different studies of adult men, adult women, female sex workers, and men who have sex with men, and estimates of gonorrhea and syphilis. And these particular studies were then used to extrapolate and develop pooled estimates for the general population. But if you're not in one of these groups, then you're not going to be well represented by the data. And so they're really, there are limited kinds of pockets of information. You're basically sampling from small units and then extrapolating to much larger areas. And WHO does the best that they can. And so you see, in certain service, family planning service clinics, high rates of chlamydia and gonorrhea, and then extrapolated to the general population, but not the kinds of robust surveillance systems that we would have in developed countries. So this leads to prevention gaps, and this is the next part of the talk that I want to talk about. Because we lack effective surveillance systems, it's really hard to know how to implement programmatic activities to reduce STI transmission. Do we need more education? Do we need more clinical services? Do we need more medications for infections that get detected and not treated? We don't know because we don't have standardized surveillance criteria. And there's a tremendous reliance on syndromic management of incidence cases, which I'm going to talk about in just a second. Syndromic management is an issue because a syndrome is a set of clinical symptoms. When you come into a clinic and you say it burns when I urinate, it takes you down a pathway, and then you're provided with medication based on the likely cause of that symptom. But even in those circumstances, many clinical sites lack medical and nursing staff that are present at all times. There are medication stockouts. There are significant shortages of equipment and supplies. Paul Farmer used to write about this as the stuff of medical care. You need stuff. You need supplies to actually to get people. You need staff. And you need stuff to get people treated. And there's a significant lack of integration with other essential programs such as HIV, maternal child health, adolescent health, vaccination. All of these programs are often siloed in global health. And Professor Gruskin very well knows this. Yeah. Okay. Thank you. So these prevention gaps lead to what I call the STI prevention cascade, and this is I think the big problem for us in our field is that we know what can be done. You start with the universe of uninfected people. We'd like everybody to be in that universe, but we know some people are going to get infected. But how do we detect them? By the time we get down to treatment, we've lost so many people. They've gone through this funnel because they need to recognize symptoms. They need to seek care. We do not have robust surveillance and screening systems for asymptomatic infections. And as limited as they are in the U.S., they're even significantly more limited in developing countries. We've known for a long time that STIs are driven to a great extent by core groups. And these are individuals who contribute to the spread of infection. More commonly, people who get STIs more than once within a 12-month period would be the focus of your prevention activities because they can spread the infection to what we call bridge populations and into the general population. But the clinical care paradox means that we have to provide clinical care to people because we know that's the right thing to do. It reduces pain and suffering, it prevents complications, and prevents the ongoing spread of infection. But screening programs are also required. And by screening, I mean testing people who don't have symptoms. And it's really, really important to do that because we need to identify asymptomatic persons. And that helps us achieve more accurate morbidity estimates and achieve a population prevention impact. I'm going to quickly touch upon, I'm running short on time, so I want to quickly touch upon the clinical service provision in low income or resource poor settings through clinical syndromes. And syndromic management is simply, as I said, when you have a syndrome, you say, these are my symptoms, and they look at a chart and they say, well, it sounds like you might have this or this, we're going to give you this medication. They don't work very well. Here, would you expect that? You go to the doctor and my throat hurts, they say, well, it could be strep throat. It might be, it might not be. Here's some medication, try it, see if it works. We wouldn't accept that as standard of care. That is the standard of care for STI because it's cheap and it's easy and it gives you something to do for the patient. You don't have to do any laboratory tests. The nurses can follow a flow chart, you can give same-day treatment, and the patient leaves with a medication and everybody's happy. Here's an example of a flow chart for urethral discharge. And you can see, you know, is there a discharge scene, no discharge scene, and by the time you get to the bottom, you know, sometimes they'll get treated, and these flow charts are widely used in sexual health clinics in developing countries. But the pitfalls are that you can't confirm the diagnosis, you can't validate the accuracy, asymptomatic patients are untreated. Because it's a syndrome, if you're asymptomatic and you've got chlamydia, say, you're not going to come into care, you're not going to be treated, you're not going to be provided with medication, and then you continue to represent a source of infection for the general population. So best practices for STI prevention include clinic-based management, but also includes all of these other elements: screening, identification, and treatment of sex partners, and programmatic prevention. By programmatic prevention, I mean outreach and activities to prevent in high-risk populations. So we've known about this for a long time. The CDC and the World Bank are involved in thinking about this. The World Bank, why would the World Bank care about STIs? Because a healthy population means an economically productive population. And people who are suffering from STIs can't provide for themselves and their families because they're either seeking care or they're suffering from their morbid conditions. So we do need these facility-based STI management programs, but we also need all of these other elements in place, and they're expensive. So I'll finish up by saying this: where we remain today, profound disparities in global STI control and prevention. In the global north, as bad as it is, we benefit from having pretty effective surveillance. We know where disease is and what needs to be done about it. We have microbiologic treatment. We have screening of asymptomatic populations to a greater or lesser degree. We have partner management. It's incomplete, but some partners get notified. And in the global south, very much the opposite of this. And so I feel like the COVID has at least magnified these existing disparities and has allowed us to shine a bright light on this inequity. And so I would say, when we're talking about sustainable development goals, sexual health fits so much into the need for us to achieve equity in sustainable development goals. Certainly, SDG number 3, good health and well-being, but also gender equality. Right? SDG number 5, I think sexual health is part of that. Reduced inequalities. And you could go even further. So if we have a sexually healthy population free of disease, they can get jobs, and we can promote decent work and economic growth, and it can help lead us towards a future with no poverty. Now, these are aspirational goals, right? These are the SDGs for 2030, but I think this is where we want to go. This is why sexual health is so important. And so priority actions for global STI equity include not just care, which is really important, and as a clinician, I think that's critical, but that's just the tip of the iceberg. It's really advocacy and political support. You can see all of these you see acronyms up here that I haven't talked much about. Elimination of maternal to child transmission for HIV, but also for syphilis, I think is important. So all of these things are on the global health agenda for WHO, but they take money and they take time. And a comprehensive sexual health network would look something like this. Not just a clinic for prevention, testing, and case management, but also all of these other integrated systems in which sexual health is situated. So I would leave us with this, maybe this is the start of the conversation. Are we moving towards a conception of sexual health as a human right? And why? Well, because the right to health is fundamental to the human condition. And sexual health is health, and part of what I've done in my career is to try to normalize sexual health. You get a cholesterol check, that's what you do, right? You're going to get my blood pressure checked. That's just part of health. Well, why not get a chlamydia check? Why does that have to be shameful? Why isn't it just health? Just getting a checkup. Right? Because you can just unwittingly have it, you're in the wrong place at the wrong time. It's not your fault, it's your consequence. And so we need to normalize and not stigmatize sexual health. And this would help reduce social, economic, and political barriers to sexual health services if people demanded this. And when I say hegemony and resistance, that creating demand for sexual health services is paramount. So what do we need? And I think this is my last slide. More care. We need to reduce the burning. So when I said getting burned, it's individuals, but it's also populations, and it's the global community. And I think that we, as the young people here at USC, can lead the forefront of these kinds of activities. No one person can do it, but I think working towards a more just and equitable world that looks at distribution of resources. And Professor Van Tellen and I have been talking a lot about COVID vaccine disparities. and the fact that vaccine nationalism entered into COVID vaccine access early on. And rich countries locked in so many doses of vaccine even before it was manufactured and shut out developing countries. And it, again, magnified the disparities that we see globally. So I think more community engagement is necessary. I would say, following along the lines of medical anthropology, critical medical anthropology, system challenging praxis, that is activities that challenge the existing status quo. Don't just accept what's out there, but actually say, why is it this way? Can we make a better system? So these are my last pictures. The enemy still is syphilis. I don't think that sailors are always the cause. You can see VD was preventing him from getting on the ship. Right, so you can't fight for your country if you got VD. You're going to be left behind. So I think we all have to still do our part. And it has been a privilege to give this presentation. I do believe that you must be the change you wish to see in the world. So thank you very much.
I have to say that was a wonderful talk, a tour de force, truly. I mean, you just brought it all together. I want to open it up to questions, and so I want to open it up for those who are online. Please use the Q&A function. And those in the room, please raise your hand, and I'm going to do my best to moderate both at the same time. And as people are gathering their questions, I want to start from you as a human, if I may, right? You opened up at the beginning that you put together this getting a medical degree and getting a PhD.
Yeah.
With a number of students, I think it would be really nice to understand why you did that, how you did that, and what the reason was for doing that. I just think that that's useful as people are thinking about their careers.
Well, thank you for that question, Professor. So I was a pre-medical student in college. I was always interested in science, and I thought science, I was going to be a chemistry major, and I was going to be a doctor, and I liked health. And then I discovered anthropology accidentally as an undergraduate, kind of fell into it. And I thought, well, this is a really interesting way to study humanity because it's a population level perspective. And at some point I asked myself, could you do both? And it wasn't as common to do this. It's more common now. There are more and more. And Paul Farmer sort of led the way in this area, but we were inhabiting different parts of the world around the same time. And so I didn't talk to Paul, but he was having those same kind of thoughts about, can you do both at the same time? What would that look like? I was able to craft, an MD PhD program that let me combine anthropology with medicine. I certainly wasn't sure I'd end up in sexual health, but I knew I wanted to look at health as a population level dynamic. And my work at WashU really kind of cultivated that because we had a program called Medicine and Society where we took interested, very bright high school students coming into college, first-year students at WashU who were interested in becoming doctors. And we showed them some of the stuff about global health inequities and about structure and about power relationships. And they took a lot of that with them and then continue to become doctors. And a lot of them now are practicing physicians that are working in not just global health, but also community health broadly defined. So I think I think anthropology gives you, and it's not the only lens. I think there are lots of other disciplines where you could do it, medical sociology. And I think USC has a lot of those opportunities here too. Political science would be
Another way to do it. No, absolutely. Yes, please. Yeah, you, right. I don't know your name, so yeah.
My name is Trisha, and I just want to thank you for the presentation. And I know you mentioned something about changing the way that we see ST, STI, and STD and making it normative.
Yes.
And normative standard. But how do we approach this in like developing countries that don't that aren't not? Because I know in Europe and in America, sexual education is mandatory. But how do we approach those in other developing countries?
It's very difficult. When I was at the World Health Organization, this was a really difficult area because many countries have laws that restrict access to care. You need either your husband's or your father's permission to get a sexual health checkup. And the WHO has to be very careful about demanding changes in laws. But I think first exposing where those access disparities are. Another way would simply be to normalize sexual health screening as part of comprehensive health care. So like I say, you go to the doctor and you say, I want to be checked for everything, and they'll check your blood pressure, and they'll check your, do a complete blood count, and they'll check your kidney function, your liver function. Why not do an STI check at the same time and just make that normative? A lot of those tests can be done either through blood work or through urine tests without a genital exam. So I think normalizing sexual health care is the first step. And then you're right, though, it is very, very difficult in parts of the world where there's still a lot of stigma. I will say, though, that with HIV, and Professor Gruskin knows this very well, that people do want care. And I think, once they're aware that there is effective treatment, people want to get treated. So reducing barriers to access, I think, is really important.
Yes, please.
Hi, my name's Joel. I'm a third-year MD PhD
Oh.
in anthropology.
Really?
I am.
Fantastic.
I think I'm the first at USC. I'd have to go through the catalogs of it.
Wow.
But,
Welcome.
I really appreciate your talk. So my questions are going to be a little more fluffy. So how do you find I have 3 questions, and you can choose any, all, kind of thing. How do you find a balance with your anthropological research, the clinical and lens that you focused on, and how are you able to continue to do rich ethnography while maintaining time in the hospital? I find that to be a tricky balance in my perceived future. And what theorists are the most helpful for you to think with, excluding Foucault?
Excluding Foucault, yeah. Those are great questions. So yeah, let's definitely chat afterwards because I want to find out more about your experience. But it is hard to do both clinical medicine and engaged anthropology. And where I have found my niche is in applied research. And admittedly, so it's theoretical. Well, it's using theory to make a difference. And so my outcomes are, do we have better throughput? Do we have more people screened? What's the focus area? Lately, it's been on PrEP, HIV prevention, pre-exposure prophylaxis, and reducing barriers to PrEP access. But I use anthropology, I use ethnographic research as a way to ask questions to find out what are the barriers that people are experiencing on the ground. Quantitative surveys will give you a lot of information, and you can analyze it statistically, but it often doesn't tell you the voices and the narratives that you can get through ethnography. So developing research that then allows a clinically engaged intervention is where I put a lot of my focus. But it is difficult because you've got, first of all, to become a clinician, you've got to pass all of the board exams, and you got to be a doctor, basically. And then you have to earn a living, and so you have to do a job that people want you to do. I think teaching is another area where you can get involved, and certainly a lot of opportunities for that. But it is, you have to, I don't know if you have to bracket them off. I've been able to craft an arena. I think sexual health is actually pretty open to that use of ethnography as a field method to help develop better ways of developing clinical interventions. As terms of theory, boy, that's a good question. Paul Farmer is a hero of mine, was a colleague, and of course he passed away, unfortunately. But I, for me, critical medical anthropology really provides an important lens. So I go back to Bayer and Singer and Margaret Locke, with whom I studied at McGill, Nancy Shepherd-Hughes. So those are some of the people that I turn to. So yeah, do stick around to find out how your program is going. You're the first one here at USC?
I believe so.
That's
Yeah.
amazing. Great. I think I saw another hand. Did I not see another hand in this area? No. Okay, all right. Okay, those of you online, there's not a single online question. So I do want to tell people online, please, to ask questions. All right, I have questions that I'm happy to bring in, but I wanted to give space for everybody else. Do you got one? Okay, go for it, and then I will.
So kind of going off of what you kind of just talked about PrEP as being like something kind of, and I mean, I feel like we didn't talk too much about HIV. We were talking about the main 3 through this mostly, but I'm kind of curious because obviously that's one of the, it's a very serious condition that is also continuing to go up, I believe, is what it seems like. And like we were talking about how it's between 4 to 6 million in the United States, between the big 3. I think the number was substantially larger for the HIV. But we do have PrEP as like a way to prevent that. What's like in our way right now from getting that more accessible to everyone? Is it pharmaceutical companies and like prioritizing profit over healthcare of people, or what's our main issue? Because we have this tool that's been recently developed, that, or at least semi-recently as far as I understand. It's like useful, but I don't know. I want to hear your opinion on that.
Well, that's a very good question. I mean, we could talk a lot about that, and I don't know that there's one easy answer. I think PrEP is, there are certainly barriers to PrEP. I've noticed in Canada, since I've moved to Canada, it's actually even more restricted than it is in the US, which is surprising because we talk about the Canadian health system as being open access, but because it's a gatekeeper model of care, you have to actually have a referral to get into the infectious disease group that can provide PrEP. So part of my work right now is we're trying to educate family physicians that they too can prescribe PrEP. There's a reluctance to do that. Now, a lot of that's happening in the US as well, that there's a perception among some physicians that they don't have the expertise to do it. It requires ongoing monitoring. There may be some moralism against using PrEP among some communities. That I've heard some physicians say, well, I don't want to empower my people, my patients to just have sex with wild abandon. And that's not what it is at all. It's a harm reduction approach, and it clearly saved lives. So I'm a big proponent of PrEP. But increasing access is part of it. It can be expensive depending on the product you use. There is now generically available Truvada, so that should make it cheaper. But I'm encouraged because I'm seeing advertisements. I was in Washington, D.C. recently, and I saw PrEP ads in the subway. You'll see ads for injectable PrEP on television now. So I think that it's coming, but there's still a sense of stigma that pervades in some areas, and I think that if we normalize sexual health, it's the same answer, right? Sexual health is health, and so it's just another way. Why, if your cholesterol is up, then take some medication to bring it down. Why not take a medication to prevent HIV?
Hi, I'm Jasmine. I
Jasmine.
appreciate your time. Thank you for coming today. I just had a question in terms of how you would go about normalizing sexual health as health amongst religious and cultural institutions who kind of condemn the act.
Well, that's a good question, and we're in a moment. I never thought I'd see Roe versus Wade reversed, and I think your generation is facing challenges that we thought were settled conditions, and I thought we were sort of on a progressive track, and we're seeing a little bit of regression around that. Professor Gruskin talked about that. Quite a bit of regression, yeah. But on the medical side, I think, again, if you talk about what is appropriate medical care for screening tests, and there's tremendous evidence of this. So getting the U.S. Preventive Services Task Force to say that chlamydia screening is an A recommendation, which means it should be paid for by every payer and should be done, for all women aged 18 to 24. That then becomes normalized as something that should be done by everybody. HPV vaccination is another one. I will say it's hard in the U.S. If you look at HPV, so take HPV vaccination, we're pegged at about 30% of coverage. Whereas other countries, Australia, which does school-based vaccination, they've got 80 to 82% coverage. And they've seen their cervical cancer rates really decline significantly. So we have this, I don't know, I'm a big fan of opt-out testing. And so that when you go to the doctor, unless you opt out of a chlamydia test, it should be normal, it should be run. But we tend to push back. There's this sense of individual, respect for autonomy, and so patients ought to opt in. I want a chlamydia test, as opposed to saying I don't want a chlamydia test. I don't have a good answer to that, but I do think that the more people talk about it, that sexual health is just health, we could move in that direction.
Thank you.
Please go ahead.
So
Hi.
my name is Giovanna. Really thank you for coming here as well. I just have a quick question about, how we talk about big three?
Yes.
And you also talked about how there was other 20 million other
Yeah.
infections
Yeah.
and other things. Do you believe that if we were, is there also a hierarchy issue within categorizing these STDs as what we should focus on, if we should just focus on the big three, or if we were to also focus on the other infections, does that mean that we can get closer to solving this disparity issue?
That's a great question, and it's not so much that the others aren't as important, they're just not as common. And so you've got so much more chlamydia. You've got millions of cases of chlamydia per year in the United States, something like 2 million cases estimated each year. And then these other infections that, maybe 500. or 200. So it's not so much that they're not important, they're just not as common. But when, I think if you made sexual health just health, I mean, that's obviously my mantra now, but if that could become a reality, then these other infections would also get detected. So we have to stay ahead, of course, of the emerging science. You know, I don't know how many of you have heard of the new STI, mycoplasma genitalium, or MGen as we're calling it. But there's a lot that isn't known about it. Some people carry it and then they're not having symptoms. Some people have symptoms and need to be treated, but not everybody who has it needs treatment because it sometimes goes away by itself. So there's still a lot that's not known about it, and we still need good basic science to help address those. But meanwhile, we're up to our necks in chlamydia and gonorrhea and syphilis, so we've got to do something about that.
Thank you.
Hi, hello. I have a question regarding the WHO organization, how they deal with different cultural practices in different countries,
Yeah.
depending on the country in which they operate.
Mhm.
And you were saying that it's difficult because sometimes,
Yeah.
like sexual health can be considered something that it's a taboo, and
That's right.
if the doctor enters a certain relationship, which is just from our way of seeing, is very partially neutral, but it can be seen as something like that enters a private space that shouldn't enter. Then I was wondering whether, since you said you work there,
Yeah.
is there any kind of program of intercultural exchange in which there is a try to explain that this relationship between the doctor and the patient is actually neutral and not touching that privacy space?
Yeah, there are those kinds of programs, but the WHO isn't. They are allowed into countries at the pleasure of the government. They're invited to come in and help with specific issues. And so the WHO has to be very careful to address the existing needs. For example, if a country is having a lot of child death due to malaria, that would be the priority for that country. And so the sexual health group can come in and they say, by the way, we're due sexual and reproductive health, but it's often restricted to antenatal clinics, for example. So they have to, there is that cultural exchange that goes on. There's also tremendous respect for the autonomy of countries so that they have access to these other areas so it's a real prioritization. And sometimes we do sacrifice, coming in and saying, well, gee, your laws are draconian and they're preventing women from, having self-determination. Those conversations often they're muted, let's say, in order to maintain access to care. So it's just unfortunately, it helps perpetuate these kinds of disparities that we see. Yeah.
It's changing.
It is changing, and so we're seeing more and more of that happening. But there's a hand down here that you can't see.
Let's go for that hand that I can't see, and then I'll take the hand that I can.
I was basically gonna kind of have those two questions that were just answered kind of in one. I was really curious, to know how you plan to make this type of because you talk about go into a clinic and make it a normal thing, normalize addressing this issue, but how are you even gonna have medical facilities want to have that type of testing happen, especially in third world countries where there is that cultural barrier and a sense of it's all taboo and whatnot, and also the fact that third world countries they cannot even survive and do baseline health care there, so it's how do you see them having this expectation of giving this type of health care, especially to women, in these third world countries where they first off don't even have enough resources to give them a baseline accessible avenue of care. Is there a discussion on that, universalizing it and adhering to those different economic differences?
Well, I would like Professor Gruskin's input on that, because that's a real important question. How do you prioritize and normalize? I mean, one way I'll ask Professor Gruskin to weigh in, but I would say one thing is recognizing that if you detect and treat chlamydia in a teenager, she can go on and have healthy babies, and if somehow that message can get put at the population level, that this is a test that helps preserve your fertility in the future if you want to have kids. To me, that would be a mechanism. That's not it doesn't answer all of the questions.
Yeah, I guess it would call for a lot of learning how to make an idea like that seem attractive across different like groups of people also. Yeah.
What's your sense of how we could prioritize?
Well, I mean, I guess that I would talk about the diversity of resources within countries, because I can't think of a single country, and I've traveled a lot, where there weren't people within systems, whether they were in government or civil society, who were trying to do the right thing around these very specific issues that we're talking about. And so I think one of the things that as people coming from the US and Canada is to be really clear and recognizing the issues we have within our country right now that are pretty significant, and having that level of taking, for me at least, it's taking the lead from my partners in the countries that I'm going to, right? And I think that that becomes really important, because I want to be really clear that I think that that health systems in general are trying to address these issues, and that it's not as though anybody's saying, oh, we're not going to look at that. The question is how they're going to look at it and how they're going to prioritize in that sense.
I totally agree with that, yeah. And partnerships, that's the most important thing. We've learned, anthropology teaches us, you can't just helicopter in and say, hey, I'm here, I've got the vaccine, aren't you excited? We did that with smallpox and it worked, but only by, sort of being very paternalistic, and it's not gonna happen again.
Please.
Just a quick question, and in my mind is the commercial for Cologuard. And I'm wondering, how close are we, if at all, to at-home testing?
So there are at-home tests that are on the market. They don't perform very well because they're antigen detection tests for the most part. So they're some of the lateral flow. We have been hoping on the STI side, all of this PCR. Everybody knows what a PCR is now, which is great because PCR for COVID. We thought that you could then convert all of those PCR tests now to test gonorrhea and chlamydia. And then you've got nucleic acid amplification, so it's a much more sensitive test. The home tests are okay, but they're not going to solve the problem. They're overpriced. They're not as accessible to the people. If you look at their positivity rates, they're actually pretty low, and so they tend to appeal to people. I don't want to say the worried well, but the people who have access to other resources and their morbidity. So they're another arrow in the quiver. I'm not going to say they're not helpful, but they're not going to solve the problem.
So what strategies would you recommend to break down those barriers in communities where they don't normally have the resources?
Yeah, I mean, I think home testing, if you could have direct-to-consumer free tests. There's a program out of Johns Hopkins called I Want the Kit, and they've had some really excellent results where it's internet-based, and then you have them mail it to you. But if you live in with your parents, or you live with a partner and you don't want them to know, having a chlamydia test kit sent to your house could be kind of problematic. There are pilot programs that are sort of addressing this sort of real-time, low-cost, test and treat centers.
And then on a different question that was in my mind is, we talk a lot about going to the clinic and getting referrals and talking to, and how much of that is actually a barrier, because those clinics have to be occupied by individuals who are educated in how to provide services to their clients. And in some countries that's difficult because the infrastructure for education and all that. So I was wondering, in what ways do you see that as a barrier and how to overcome that barrier?
Well, self-testing, so you talked about home kits, but self-testing where actually people can go and get a collection kit, and a lot of times these are urine-based tests, could also provide access to people who otherwise don't. You don't necessarily need a clinician there. Now, you do need systems in place to collect the specimen, actually transport it, and have it tested. But as I say, some of these COVID PCR tests can be done in low-resource communities, and if we can get the technology into those areas, I think that would help.
Please, go ahead.
I'm Saran, PhD student. Thank you for your presentation. I guess my question is more so related to the word weight, because a lot of us are concerned about Planned Parenthood, for instance, getting affected by kind of this conservative backlash in some of the states Planned Parenthood also does like a lot of good services for STI testing, for instance. Do we see this kind of like affecting maybe some of these clinics and how they operate?
Oh, yeah, so Planned Parenthood is the second highest chlamydia tester in the nation after public health clinics. So they do a profound amount of clinical care. And so abortion services is such a small part of what they do. Shutting down those clinics reduces access to care. And so we will see rates go down, at least in the short term. But we're going to see, complications down the road. So I am concerned about that.
So I think Professor Antel had a question, and that would be our final question as we wrap everything.
Dr. Stoner, thank you for a brilliant presentation. It was really, really inspiring and interesting. I was just thinking a few things because Professor Gruskin, when she came from Harvard, arranged a conference on non-communicable diseases, and we haven't really discussed that at all. And I remember when you chaired also, Professor Gruskin, the group on global health and law, there was discussion of AIDS and whether there should be sanctions for people who intentionally infected partners, and the question of partner notification, but using that approach would further stigmatize, and also partners may not be known because of the way people meet each other. So I guess I'm wondering if normalizing sexual health would help people voluntarily notify people to the extent that they can. And then I was also remembering Professor Gruskin's essay on Ebola and cultural barriers to Ebola in response to that question. So I didn't know if you wanted to say a few words about those.
Well, I mean, there really should not be any laws against transmitting STIs. So many states criminalized HIV transmission early on in the epidemic, and there's still people serving prison sentences for knowingly infecting partners with HIV. But that really does create a barrier for testing. People then say, well, I won't get tested. I might have HIV, but if I find out I'm positive, then I'll be criminally charged if I tell people. So to me, that creates a barrier for detection. So I think it's regressive. So I'm against that. I think we should have, like, you have no-fault auto insurance. I think we should have no-fault STI disclosure. And some states have tried this, partner notification through internet-based or text-based messaging. But then people can abuse it. You go on and there are these websites where you can go and tell your partner. If you get chlamydia, you don't necessarily want to tell the person who gave it to you. You want to notify them, but you're kind of mad. So you can do it through some web-based services. But then other people maliciously tell other people that they've been exposed when they really haven't. So some of those systems have really been shut down. So it's complicated.
But your work on Ebola, you found people had to say goodbye by touching people, and how did people change that attitude? Wasn't that part of your work?
It was, but again, this is about Dr. Stoner, just to say very, very quickly, it was, and I think one of the things is that there's such a human desire to touch, and there's such a human desire for that contact. The issue then becomes when you know that that's something that's unsafe, how is it that you then can have closure, even knowing that you need to do that? And I'll just say very quickly, in terms of right now, we have some very close colleagues in Brazil who've done some amazing work about during COVID, about people having their first sex during COVID. And the issue of leaving their house with their grandparents and their parents to meet a partner, and then to come back and to deal with the mental health issues of the guilt, because they recognizes that both that they were sexually active, but the fact that they could have infected the family that they love. And so that issue is, I think, kind of fundamental to that.
Well, that's very complex. I hadn't thought about that. That's profound.
Right, that's really interesting.
That's profound.
Thank you both so much.
No.
Oh, I appreciate the opportunity to speak to you. Thank you for spending an hour and a half thinking about these things, and I wish you very good luck in all your work.
And thank you all for being here with us. Thank you very much.